So I really hate to disrupt this conversation because it's so robust and so important to us. So, but I will. Only because we have a little other work to do before the evening starts. So this has been a very stimulating day and a certainly stimulating panel. I want to thank everybody. Marion, for your moderation, Stacy for your expertise, Donna for being my friend all these years, Dana, Anne, and Reverend. I really enjoyed the entire presentations, and I'm sure the audience did in addition. So thanks again, everybody. Let me just now... oh. Yeah, there is, right here. Got it. Got it. And it's on. It says on now. Okay, we got it right. So let's move to another aspect of what the roundtable does very well. And I'm going to ask each roundtable member. Now, I don't have to ask each one because you may hear something from somebody else that's already been said, and that's perfectly okay. We don't have to go to everybody. But I would like everybody who can to make a point or two about what you heard today, a sentence or two, so that we can get through the entire roundtable and really try to think about what you got from today in a sentence or two that everybody in the room can hear. So I'm going to ask who wants to start first before I choose. And Michael, thank you for that volunteer.
I'd also like to echo the thanks for the panels today. This was a great discussion. I'll be a little bit of a devil's advocate here and say I think that the health literacy component of this was probably not quite as robust as I might have liked to have seen. I don't think it's through any fault. I think a big part of it is just the fact that there is a pretty far chasm, I think, right now between, as our panel, the title of this panel today was palliative care and health literacy. I think there's an awful lot of steps in between those two before we can really marry those up. I think number one is awareness of palliative care and what it is, and we saw that even in statistics. People aren't even aware of what palliative care is, and before you can understand it, I think you have to know that it even exists. We have a very odd culture around death in this country, that we tend to shunt it. We don't like to talk about it, and so I think a lot of the issues around death, dying, and palliative type of care, there's a lot of those things that need to be addressed first before we can enter into meaningful conversations about health literacy around palliative care. I also think a lot of people who are coming into the healthcare system now who have never had health care under the Affordable Care Act, that even puts them one step further away from understanding that. And I think there are issues still around access. I would say I don't believe, and I'd love to be proved wrong, but I don't believe everybody in this country has equal access to palliative care, let alone just health care. And so I think we have a lot of work to do there around the social justice issues around palliative care, which is kind of a step removed from just access to regular health care. But thank you to all the panel members today.
Cindy?
Thanks. A few points. One, I just want to respond to Michael, so it's a good thing that I'm going second, so I wouldn't be responding to half a dozen people, which is about the health literacy content of today's work. I, as most of you know, have a very broad view of health literacy, and to me today really spoke to the part of health literacy that has to do with reducing demands on patients around navigation, around coordination, as well as understanding under difficult conditions. And so I wasn't troubled by the fact that a number of the speakers didn't make use the words health literacy to make the connections, but I think that the kind of care, the model that we have in our head of the care that we want provided in this country for people with advanced illness is a health literate model. So I was comfortable with that. Two big points, I guess. One, my agency, the Agency for Healthcare Research and Quality, does a lot of work around error reporting and does a lot of work in patient safety. And when I was listening to Bev talk about her experiences with the fact that the DNR wasn't in the system, the fact that there were delays in getting medicine while she was in the hospital, the fact that, you know, she had these 48-hour prescriptions that she might not be able to get to the pharmacy because of snow, or, you know, these are system failures that are errors. And if we had a sense of, you know, we should be collecting and reporting these and considering these medical errors. And when we talk about a culture shift, we are already trying to get a culture of safety in our healthcare organization, then this is exactly where these issues lie for me, that part of that cultural shift is embracing these kinds of mistakes that are being made as part of the things that we need to correct and prevent. My second and last big comment was, I'm still struggling with palliative care as a distinct concept, and I had I related to Bob's comments in terms of if it's, in some ways we've drawn it so broadly that it's just good healthcare quality, and in particular, thinking about, you know, there was the issue of the social support that we provide versus that we would want to provide to every person as opposed to people with advanced illness. And so while I learned the clinical term, the dwindles, I wonder how, you know, that distinction between people who have the dwindles versus people who have advanced illness, where palliative care, does it really embrace everything and all of it?
I'm going to remind everybody that a line or two, because we are taking some notes, and I do want to get to everybody on the roundtable. So just a line or two so we can make a point or two. Margaret?
Yeah, thanks everybody that spoke. It was a wonderful day, and I had several takeaways, but I'm going to only concentrate on one, and that was about the physician training. And I trained centuries ago when nobody even talked about end of life. And now I think it's extremely important because end of life is a chronic disease, and that physicians, all physicians, as I think Diane said, need to be trained on communication, these difficult communication, these conversations that are hard to have, that are, you know, I know when I first started, I was anxious, and it takes practice. But if physicians can be better prepared, not just oncologists, all physicians, and I don't know how to do it, and I think that's a problem, you know, whether they're prepared in medical school with actors or videos or whatever, but they need to be better prepared. And at the same time in this physician training, I think the concept that came up of being part of a team, that we, you know, physicians, even though they're the medical captain, the captain of the medical training, they're still part of a team, and that's really important. And the other aspect of their training that Reverend Freeman, you emphasized is, you know, we're really good on the body, not so bad on the mind, but we don't really acknowledge that there's a spiritual life. And I think that part needs to be incorporated so that physicians and healthcare providers can approach their patients or people with the concept that they do have a spiritual life as well.
Thank you. Maren?
One sort of overarching thing and two quick friendly footnotes. The overarching one is something that concerned me through the day, is something that I've seen in a pattern of discussions about differing topics, and that is, as you went down the lists, the communication that we were actually talking about as the health literacy interaction ended up down in the list, usually followed by or preceded by education. And somehow, if it's the macro piece, if we end up with it as part of a strategy, not even a strategy, a tactic, it is not going to get the kind of cross-pollination, I think, that we're going to need across the fields. The two friendly footnotes I was going to let this go, but there are too many physicians in the room who are practicing, and I just wanted to throw in this note. There were discussions about translation, and there was a comment about, specifically with deaf individuals, that the interpreter was asked in this small community whether the interpreter was comfortable with doing the interpretation. It is the patient who really needs to be comfortable with the reputation of and the language use of the interpreter in deaf settings. And the second quick footnote is the teach-back system, since a lot of you are from a different field, is Dean Schillinger's work from UCSF. And he built that notion on a bigger communications strategy issue, which was feedback, which was well known to both Hippocrates and Demosthenes, but only recently kind of recategorized. And it was brilliant because he allowed physicians to understand that system in their own terms. So I think it's really worth for folks who haven't, looked at that literature from palliative care to look at Dean and his students' work.
Marion, are we all comfortable with using the word person rather than patient as we move this conversation forward?
Me?
No, I just asked you because you were.
Yeah, I think person is a really good term.
Terry?
No, I thought today actually far succeeded. I kind of came in with mixed feelings on the day, and the presentations far exceeded my expectation. I think the value of having the family voice, or speaking of the patient and that experience, is wonderful. And I think as a roundtable to incorporate that whenever we can really gives us that full spectrum for us to take a look at. And also having the reverends here, I think, was a wonderful value added. And the other part that I think we kind of touched on at different points throughout the day, but at the end it really came to fruition, was the value of clinicians, and all providers taking that time for self-reflection and to look at unconscious bias and baggage, or however we want to label that, and how does that enter into those conversations? Because I think it does much more than we acknowledge and give credit to. And I think that's a very valuable point that we should, continue to look at.
Thank you. Rob?
I got a strange take-home point from today. Probably a little different than the rest of you, but let's give it a try. First of all, I deeply appreciate the day. It meant a great deal to me personally, and I won't go into that. But it was very meaningful throughout the day. But in addition to the healthcare delivery system, where are some other venues that health literacy interventions can be constructively delivered and assessed? We had a couple of presentations today that argued, I think quite convincingly, that home visitation provides an enormous opportunity, as much as some of the public health research we've heard about in the past has reminded some of us that community-based research provides opportunity as well. After today, I'm a lot more impressed with some of the life skills progression and other research that's been funded about home visitation and how that impacts health, wellness, quality of life, and actual health outcomes. I respect that evidence a lot more today as a result of sitting through this. So I thank you all very much.
We'll have to define the community sometime. It's a big word. Suzanne?
Yes, it was a very interesting day. One of the things I was struck by, and coming at it from the perspective as a nurse scientist who does informatics research, was just where there are some real gaps in the technological support to make this happen. Everything from things that might be clinical decision support, but also some of the consumer-facing things, getting experiential visualizations, other types of strategies around this that might occur much earlier in the course of things. So just thinking about some different types of tools that might face different stakeholders and really take advantage in making the existing knowledge assets more accessible to a broader constituency.
Winston?
2 points. One, with regards to the question of palliative care and how we define that. I will say that I think language and culture in our lifetimes is most accentuated in what are kind of sentinel moments in our lifespan, i.e. birth, marriage, and death. And I think all the aspects around how to communicate effectively become really distilled at those critical moments as we have to reflect on our lives and our families. The second point here is I think there's a political stake that needs to be stated with regards to making sure that we capture the narrative in partnership with community and clinicians around what this is all about. And the point I'm making here is we saw several years ago how the narrative was captured, I think, in a very opportunistic way of calling these discussions death panel discussions or what we should do with Granny. And there's a point in time where we have to make sure that people throughout our communities really understand what the nature of these conversations are, and that there's no deviant way of how to frame these discussions. And if we agree on what the nature of that discussion is, I think we would have made a contribution towards improving what health and medicine, death, dying, and dare say living are, for people throughout our communities.
Thank you for that. Wilma?
I just wanted to echo that as well. You know how folks said they don't like following a preacher. It's similar to Winston because you're always making some amazing comments. So kudos to you. One of the things I want to say is too also regarding the cultural linguistic piece and some even nuanced information. The comment was made regarding the deaf community and the importance of the deaf patient and their perspective regarding the sign language interpreter. And as a spoken language interpreter, it's a little bit different. So this is really nuanced information. But what does that mean when that's part of the equation in an area that's just so sensitive? So I think, again, I could talk about this forever. And so just talking about some of those things and the cultural piece that is involved with these areas when the intersection of health literacy and palliative care. In what language do you get sick? And in what language do you access your emotions? And so what are the next steps to the work that folks are going to be doing? Overall, I really, really enjoyed having Carol speaking and others speaking as well from their perspective. And Bev, I thank you very much for your openness and sharing everything. I really, really feel that hearing is from that perspective and having the opportunity to see it through the lenses of individuals who have had that experience has been amazing. So thank you.
Alicia?
I very much enjoyed the day and thought that the presenters were wonderful and gave beautiful examples of teaching programs and clinical programs and community programs that really have excellent ideas in them. At the same time, it really struck me of what an early stage we are in when we talk about these things, and how much we're not yet ready or to fully grapple with the forces that are going in the other direction, with chronic disease care becoming increasingly fragmented, increasingly the burden shifting even more to patients and caretakers, and how little of the conversation still, and I know it will evolve in this direction, is about grappling with the health system. So I thought I would take advantage of this to make 3 small points about unintended consequences. One is to have palliative care friends and colleagues, which is undoubtedly it improves care for those individual patients. And one unintended consequence is The morning after, my team admits a patient, and I say, wow, this guy's really sick. Have we talked to him? And they said, oh, we called palliative care. And the unintended consequences of perhaps worsening physician involvement. The second is on the unintended consequences of the systems we already created. A huge issue for me with my patients is around the way that I can get hospice paid for and can send hospice out. And hospice involves, the first thing they explain is, and you can't go back to the hospital. At which point I need to call the patient and say, don't worry about that. You and I know that we're going to do this, how we're going to do this. Of course you can go back to the hospital. What are they going to do, turn you away? And it is an extraordinarily culturally incompetent system to have created with that restriction in place. And I hope for my palliative care colleagues and for the rest of folks to carry that banner. And perhaps that will be carried if we move into payment for palliative services rather than hospice. And the third point is simply around caretaker burden, that I think we need to increase the conversation about the low levels of literacy and management and vulnerability that our caretakers have in a system that increasingly asks them to do the $240 billion work that's being done. Thank you very much. A wonderfully stimulating day.
Kim?
Yes, thank you, Kim Parson. And I just want to thank everyone today for, again, as my colleagues have said, a wonderfully stimulating day, particularly those who shared their personal stories. And that just moves me to talk about the message that we need to take away from today is that it's not our journey, it's their journey. And we need to understand where patients are, or where people are, Bernie, in their journey, particularly as we think about people with multiple conditions, and that this journey where they are sick, maybe many, many years. And when we think about the burdens that they have on them and on the caregivers who are stepping up and doing so much care during those many years, how increasingly hard our system is on them and being able to make the right decisions, because they're in pain, because they're sick, because, they're tired, not the least of which, our system is very hard to understand. And then the other point that I'll make, and this was just about something that was mentioned briefly this morning about not knowing about cost, not being a barrier, that people weren't worried about that. And I'd just like to say that I think that people even people who are able to afford co-insurance and co-payments, are worried about cost, particularly if their care is, or if their sickness, is a long-term thing. And I think that when care is ongoing like that, sometimes years, even the smallest amounts, or what may seem like small amounts in the one-offs really do, cut into people's monthly budgets, and even into people who, maybe aren't living check to check on a monthly budget. They're still concerned about their families and the burdens of costs that they may be leaving on their families, in addition to the burden of caregiving that they have. So, I just stress for us to think about the need for that transparency, and also just to really push and stress for the importance of integrated care delivery as big takeaways from today.
Thank you. Lori?
So I will follow Lauren in saying one thing in 2 footnotes. The first is that I really liked early in the day when folks said people, even with the lowest levels of health literacy, know everything they need to know about their goals and values. And the responsibility is on us for the communication and really that shared decision making. I thought that was profound and really important throughout the rest of the day. And making sure that folks have not just, that a person has not just a seat at the table, but a voice at the table in team meetings. That really resonated when you said that as well. And also the fact that that team includes also the pharmacist and medical assistants who are often answering the questions when patients are thinking and later. And I love the idea that someone spoke of this morning about using the same language across the health system. I thought that was really an innovative idea, that if you train doctors, nurses, pharmacists, medical assistants to use the same language, that really could help, I think, to decrease the stress and anxiety. And then my 2 footnotes are the role of mental health in this, and depression and anxiety. And I think thinking about that, somebody said in your living will, not just having about pain medicine, but about anxiety meds. And that just resonated, having witnessed this in my own family. And the second was in terms of educating the person around the decision around palliative care and what happens when members of the family don't understand that. And so when they've come to the point where they understand that treatment doesn't make sense anymore, what happens when other members of their family think they're giving up, and how do we help prepare people for those difficult conversations as well? So thank you.
Thank you. Terry?
You got it.
No,
That's Nike. Okay. We talked a lot today about communication, and a lot of it was communication with the patient or the person and their understanding of what was going on, their values, their worries, their wishes. But then I realized in listening to everybody, there's so many different people involved. I mean, I guess the good news is people don't live in silos. Most people, they have family and they have people they're connected to in the community groups, faith-based groups. They have a primary care provider. They have an oncologist or other specialist. And then I'm wondering, are we talking to each other, Alicia? Are we using the same language? Are we giving conflicting information? And then in healthcare, we like to say, who's in charge of the team? But it's like, there's not really a hierarchy here. The patient is at the center, but sometimes we don't give them the power to be the team leader. And so it's just, I can't figure out the playbook here. It must be very confusing to patient and families, and no wonder sometimes they feel so alone and overwhelmed. And that's a lot more than health literacy.
Maybe we don't need a team leader. I'll talk to you about that later. There's an interesting book that was just written called Team of Teams by General McChrystal. And it's a terrific book because it addresses some of the issues that you've just begun to raise. So if anybody has a chance to read it, it's something worthwhile. Chris?
All right. This was very good. I was struck this morning and was touched by Beverly's testimony, and was flabbergasted by Diane's point that the same gap still exists today. So we really haven't gotten too far. Reverend Dr. Pitts said something pretty profound. A lot of what he said was profound, but what struck me was at the end of you don't have to do it alone, but you followed that up. But do you want to? Okay. The point I'm getting to is accountability. You know, we can talk about all the nice things we want to do, and we're moving the wind around. All I really want to say, and I have a couple of cards too, is that I think that the importance of palliative care, along with health literacy, are necessary at the table to decide what the playbook is, really to create patient-centric performance measures and quality measures. Because one point I'm willing to wager, Beverly, during the course of your trials and tribulations, and over that 10 years, I wouldn't be surprised if the institutes you were working with got very high-quality grades, all right? And we mentioned the word quality, and we have to, and I'll go back to Reverend Pitt, we have to want to. Are we okay with quality as it is, or do we, is the present situation unacceptable? If it is unacceptable, then we have to set up the parameters. And like I said, I work in the quality and performance measure space. I have a number of folks' cards, and I'll be drawing some in because at the very least, you need to be at the table to set what that is. That's all. So thank you.
Ruth?
So I'm just going to put on the record one more time that I think this is a wonderful opportunity for those engaged in an incredibly important issue to take the organizations of all the caretakers who are involved in palliative care and look at the issue of cost and whether or not it needs to be at the table and needs to be a part of health literate discussions about palliative care, how those conversations would become communicated as communication itself is such a great challenge. And this seems incredibly ripe given that, at least from my little search, it looks like palliative care is fairly new as a field in and of itself. Hospice in America, likewise, is fairly new. They have roots in words that have great meaning, coming from the root to cloak, as I understand it. So how we cloak an issue like dying, which is always going to be sad and always going to be hard. And to think about right now for the United States, if issues of cost, which we've identified in terms of clarity and understanding are a part of shared decision-making, belong in this very big zone that presents a lot of complexities for us all. Thanks for your comments today.
Michael?
I love this topic. I'm so happy that we had this this day, and there are really lots of wonderful sparks that have come out of people's different talks. I think that this topic really exposes an interneshing iatrocultural struggle that's going on between folks in healthcare who care about communication and folks in healthcare who are at war against death. And that's still an ongoing struggle. I think there's a great topic that we saw hints of how political the topic is, how many justice issues are at stake, and also how complex it is. And I think that's really one of the reasons why this is such a great topic for the Roundtable on Health Literacy is that it is actually quite complicated for patients and families, and we actually can improve that. And that's one of the reasons why it's so fun to work in this space, the palliative care and end-of-life space in general. And yet there's still lots of lack of data. There were a lot of holes in data. So I would say we're still quite green. It will still take a team. But if we have that dream, results will be supreme. There you go.
There you go, Michael. Lindsay?
Boy, that is a hard one to follow. Wow. Well, I have just a general comment about the day and then a point to make, because as the only dentist, maybe the only dentist in the room, I'm definitely the only dentist on the round table, but it was just a tremendous day, and I thank everybody for their personal stories and the patient stories from the clinicians too. Very resonating. I went through a process with my mother. She was dying about 3 years ago, and I think a number of people in the room have had that personal experience as well. Very difficult to deal with, and I really appreciate having the spiritual counselors in the room too, and having their voice at the table, just really to remind us that the big picture means that we really are, at the end of the day, tending to broken hearts of not people, but human beings. That's what we all are in this room. Going back to what Diane said in setting the context about integrated palliative care strategies as a medical counterculture, clearly the system is not set up to work together in a collaborative or integrated way, and this especially is true of dentistry. And dentistry, I mean, it's very partially our own fault. I mean, we have worked hard historically to stay out of Medicare, stay out of the healthcare system in general, to be carved out, to do our own thing. But times are changing, and dentistry is realizing that. And so you see the commitment. I'm funded by the American Dental Association for a reason, because we want to have a seat at the table. We want to have a voice. And increasingly, there are opportunities out there where we're working with the American Academy of Pediatrics and pediatric care, family physicians, ACOG for pregnant women. This represents another opportunity to work across the life spectrum, the end of life. So I will be taking this back and looking for opportunities to work in this space with you all, because clearly oral health plays a large part in overall health, especially when it comes to the treatment chemotherapy patients, where you have serious side effects, mucositis, that can impact the health outcomes. So we'll do some more talking, but thank you very much.
Jennifer?
So I've been reflecting on today's talks, beginning with Diane Myers. I really appreciated that. I trained as a geriatrician and received some training in palliative care as part of that. And what struck me about today was the great dysfunction that we have in our health system, and it made me ponder whether the development of palliative care as a discipline is really a response to the low health literacy of the healthcare system. It seems that it's a way to shepherd people with advanced illness through the end of their life because the system's health literacy is so low. And I think that perhaps by naming health literacy in palliative care, we can strengthen both the health system and palliative care as a discipline. So.
Thank you. Katina?
So much of the comments that have already been made really speak to how kind of the deep content that we learned about today. So I want to say something else that I'm maybe going to get a little bit incorrect here, but and it's the attribution that I might get incorrect. I'm not sure if it's the topic of palliative care or if it's the planning committee or if it's just kind of luck of the people that were brought together or whatever that is. But something about today and the things we learned were kind of more deeply personal and political and social justice oriented than so much of the work that we often get to talk about. And very specifically, we heard comments from Reverend Freeman, for example, that, it's really important for us to use our voices, all of us here, for social justice and power and privilege, and how we make sure that these resources and access to care at all levels is appropriate and accessible to everybody in our community. I think that is just such a powerful message at this time in the world and in the U.S. And so I'm excited about that. And as always, I'm really excited about seeing community members so visibly active and given the same voice and kind of energy as other people with academic credentials and kind of the weight that often show up at the IOM. And it just felt really good to kind of see that diversity on the panel and really, frankly, every way that mattered. We had patients and caregivers and community folks and also academics and everybody here. So I just want to congratulate every single person involved, planning committee, and also the folks who really pushed this topic forward this time last year, because it's been great.
Last comment, Steve.
Yes, thank you. And want to thank everyone who presented and worked today to get this program together. I found it to be a very powerful series of presentations, which are very thought-provoking. I appreciated the focus on the provider system issues versus the patient deficit, which we've been moving towards. I also like the focus on the concept of patient-centered care as relates to health communications. Stacy and it's Dana and I are actually working on some committees together. Just found that out. And I'll be able to take the learnings from today and put that into the advisory councils that we're on. Thank you.
So before we end, this really was a terrific day in a variety of ways, and we've heard it expressed throughout the roundtable members. We'll go through this again tomorrow at our session just to get a few highlights that we can then perhaps have a more concrete and focused discussion on tomorrow. I did ask Reverend Freeman to make a final comment for the day, and he agreed to do so. So, Reverend?
Okay, thanks. Final comment. I recognize in the reality of humanity, of everything that I do, that everybody doesn't approach this from a deist view. I do. I honor that reality, and that's okay. But what I'd like to do, and I was asked to do, is just to just connect our hearts in a moment of prayer. You know, this is a spiritual journey, and every one of you that do it, you're a spiritual being. Just look at yourself and say, I'm spirit. Come on, I'm spirit. I'm spirit, and everything that I do touches somebody else's spirit. So if you would, just join with me. By all that is holy, how we know you, whether we call you Elohim, whether we call you God, whether we call you Yahweh, whether we call you Allah, whether we call you the Great Spirit, by every name that we hold dear, we come to you now to infuse us with your power. Give us the grace to walk with people who are going through the valleys of the shadows of death. Help us to walk with those who are in pain. Help us to reach out our hearts and our hands to minister in the only way that we know how we've been trained. But we also ask that you would challenge us to grow to a higher level, to a different place, so that we can be even better in the journey that we are in. Now, as we get ready to leave this place, we go with some fears, some learning, some trepidation, even some prodding. We ask that you be gentle with our learning. Be gentle with us as we come better at what we do. We ask these things in your holy and righteous name. Amen.